regarding the same?
Yeah, no, I think what we're going to have is a bit of an open forum, an open discussion, just in regards to all aspects of clinical safety. It's not just about protecting your body parts, as in your back and your shoulders and your arms, but it's also about making sure that the treatments that you are giving the patient is safe, are appropriate. You're understanding why you're doing techniques, what the outcome you're trying to achieve is, and making sure that you are looking at the whole aspect of therapy, you know, from an educational perspective, from a rehabilitation perspective. Safety, as my colleague Jimmy's just highlighted, safety is key. Do you know what I would always say to students is that no patient has ever been harmed by under treatment, as in within a physical therapy setting. You know, no patient's ever sort of walked out of a treatment room and gone, oh, he made it much worse. If you don't do anything, what happens is when you do too much, or you use the inappropriate techniques, or you're not following safety or screening, or you're not following common sense, that's when people come unstuck. So safety is, as my colleague Jimmy said, paramount. Ultimately, we want to be safe at all times.
Exactly, I believe so. Because, you know, I know a person, a therapist, like they're on a big clinic here, and they were like, we do everything. So in a session, they do everything, like they spend 1.5 hours, 2 hours, and they are like that, we do each and everything just to make sure the pain comes down. And then there's a complaint from the patient side that it might trigger the things. It might be risky for the patient if you try everything, what I believe.
Do you know what? I'm a very big believer in less is more. Okay. Yeah. If you, and do you know what, from a personal perspective, when I was a very young therapist, I would throw everything at my appointment, at my clinic. So you came and saw me in clinical practice, and I would chuck everything at you as I could. I would rub you, wiggle you, whack you, pin you, strap you, spin you around like a plate. I would do everything I could to try and let you walk out pain-free. But then how do you actually know what's worked? If you chuck everything at your patient, how do you know what's actually been effective and what hasn't? Because some of my patients respond very well to manipulation, others don't. Some respond fantastically to mobilization, some don't. Some like acupuncture, some like dry needling, some like exercise. So you have to tailor the treatment to the person. And if you crack it, rub it, wiggle it, whack it, stretch it, strengthen it, educate it, you know, you don't know. Jimmy's put a little post up there, layering the treatment. And that's really, really true. You have to layer the treatment. Make sure that you see what works. You can always add stuff in. You can always add more technique in. You can always add more manipulation. You can add more therapy, add more K-tape. I don't know, add more rock, but you can't take it away. That's the problem. You can't take it away. Layer like an onion.
Exactly. And you know what? If the patient, if suppose the patient don't respond to treatment or doesn't get better, you know, then you won't have any plan B, because everything you have just put in one time, you know.
Well, yeah,
and
you're
not
what?
going
Exactly. Jimmy said you can't take it away. You have to be in a position where you layer the approach, you see what works. I would always say, actually, in regards to safety, if I have a patient that comes in and they are in acute physical pain, sometimes the safest and the most effective therapy is actually not even touching them. It's educating them, telling them that they're going to be okay, reinforcing a positive mindset, screening for red flags, managing their expectations, making sure they understand what the common process of their condition is going to likely take. Lower back pain, all right, 4 to 6 weeks. We're looking at this, we're looking at that. We're expecting it to do this. We need you to move, we need you to exercise. You're going to be okay. That can be much more effective than trying to crack the bejeebus out of someone in a hope that you are going to temporarily modify their symptoms. You know, so like I said, safety's key. Don't chuck everything at something. You've got to, do you remember what I teach, Rohit? I say you've got to romance the patient, yeah? You've got to woo them. Dinner, drinks, soft lighting, candles, a nice meal. Don't just
Yeah.
don't just go straight in there. Just, you've got to layer your treatment, woo them. If you take anything away, romance the patient. Obviously not in an
Exactly.
unprofessional manner.
Yeah.
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 Yeah. What are you doing to a patient? Dinner and drinks, my darling. Don't do that.
Yeah.
Don't do that. But romance them. Layer what you're doing, then you'll see what works. It's really
You know,
important. It's really important.
yeah. It's all about the tissues, the structures we are going to work. If you want to alter them, if you want to do anything like mobilize or strength or anything like, uh, you could go for kind of exercises, but if you try each and everything together, and it's gonna spoil the tissues, I believe. So it's
Right.
gonna be,
Listen, do you know what? I say to my patients, right? You're not going to get a six pack in 6 days. Unless, this is a sustained approach with education, with nutrition, with exercise, with lifestyle changes, with strategic exercise and tissue loading and dietary changes. You
yeah,
don't expect things overnight. It's about managing the patient's expectations. It's about making sure they understand what it is you're looking to achieve. I think one
exactly.
of the big mistakes therapists make when they get patients into clinical practice, they don't have a good dialogue. They're not explaining to the patient, look, this is what we're looking to do. This is what I intend to see. This is what I want to achieve. They tend to try and they want the biggest bang for their buck. They want to basically hear that big crunch. They want the patient to be Cirque du Soleil cartwheeling out the door. It doesn't always happen. And I say to my patients, how long does my usual treatment? I'll answer that. I say to my patients, this is teamwork. This takes time. You may not leave here feeling fantastic. You may still be in discomfort. You may still be in pain, but this is a slow progress. For me, clinical practice, I have an average of around 30 minutes. So I see a patient in about 30 minutes. And that's because I've been in clinical practice for about over 15, 16 years now. But when I was a lot younger, it was an hour. Then I got better at questioning, better at patient handling, and that went down to 45 minutes. Now I work in around 30 minutes. But that 30 minutes may not be treatment. So if a patient comes into me and says, I have this condition, I may spend 30 minutes just doing a thorough case history, because the case history is far more important. It's the most important part of your treatment process. Case history is what makes you safe, right? Not being amazing at manipulation, not being amazing at mobilization, not being amazing at P&F, that's irrelevant. That's very good skill. What makes you safe is a very good case history. Understanding presentation, pattern recognition, asking the right questions. What makes you safe is knowing when not to do something. Bang. That's what makes you safe. Not how to crack a joint, knowing when not to crack a joint.
Yeah. So like you are saying 30 minutes, the Jimmy is saying 30 minutes, but I spend around 45 minutes on my patients. But what do you have to say about the therapists who spend like 2 hours on the patients,
Look, ultimately, if we were in the perfect world, right? The perfect world, I would love to spend 2 hours with my patients. I would love to sit there for 2 hours and have a coffee, talk to them about look at the biopsychosocial aspects of their condition, talk to them about their presentation. I would love to go through that level of in-depth research, because when you treat someone in a very short space of time, you can get very blinkered. And we know we need to step back and look at the person, the whole person. But we don't live in that world. We don't live in a world where we can spend 2 hours unless you're charging crazy money. In reality, the general practitioners in the UK have around 7.5 minutes per patient. Osteopaths on average, you're looking at around 30 to 45 minutes. Look, more treatment does not mean you get a better therapeutic outcome. So if I spent 5 hours with you in clinic, it doesn't necessarily mean you're going to get better results. I would always say be as effective as you can, as long as you're educating the patient and they are understanding that the key emphasis is what they do away from clinic, their nutritional changes, exercise, rehab. then I think it's really that's more important. I think what they do off the table and outside the clinic is probably more important than what we do on it. So 2 hours in clinic is irrelevant if they're going to spend 2 hours with you and then go sit on the sofa eating biscuits for 5 days, until they come back. Do you know what I mean? I could sit there with them in clinic for 6 hours, but if they're going to go straight back to their office desk eating biscuits and crisps and doing no exercise and doing nothing else, then what's the point? You know what I mean? What's the point?
Exactly.
Well, it's
Because
lovely.
it's not the therapist only, it's the patients, the family. I mean, everything is involved in this. So if we are talking about the safety of the patients, I have something to share with you. When I was working with the Apollo Hospital, which is one of the biggest hospitals in India, long ago, like 4 years ago, within a 1 year, three of the therapists were working in my colleagues. Three of my colleagues got the disc bulge when they were carrying the. When they were working with the patients, were lifting them in neuro rehab, in orthopedic rehabilitations. So how important is there, like the body mechanics,
Oh,
their position?
listen, look, ultimately, you can be the most amazing practitioner in the world. You could be the osteo, physio, chiro guru, and you can be amazing. But if you can't actually treat patients because you've injured yourself, then you're no good to anybody. I will always say, you can, I would always say you are the most important person in the treatment room. And therefore, it's very important that you understand your biomechanics. Look at social media. Look at people doing technique on social media. Look at their body position, and you will see some of the most fantastic techniques being performed by people who are compromising their wrists, their elbows, and their backs. I look at practitioners all the time, and I think, do you know what? That is a great neck manipulation, but in 2 years' time, your AC joint is going to be destroyed, your shoulder is going to be bad, and you're bent over like this. And
Exactly.
and you're just to gain power. It's all about finesse over force. Your biomechanics not only makes the technique easy, effective, and safe, but it also gives you longevity. Jimmy says this better than I do, but I think he sums it up when he says some of the most effective therapists in the world are some of the most laziest.
Yeah.
And when we say lazy, we don't just mean like lazy. We mean they are biomechanically effective. They protect their back. They do as much as they need to, no more, no less. They get the job that they need to do done, and that is it. They protect themselves. They're the guys that will be manual therapists in their 60s, 70s, 80s. We work with an osteopath who actually, ironically, was originally an Indian bone setter before he came to the UK and studied osteopathy. He's in his late 80s. Technically, his positioning is phenomenal because he doesn't compromise joint. He's using his hip biomechanics and back. He's using his body. We've just finished a filming project for an online training academy for OMT training. So we're looking at bringing technique online. And a lot of it is about how we position ourselves, because you can't really see it in a 30-second Instagram video. It's all very much, fireworks and click and crack and woo, look at me. But in reality, the intricacies of the technique is not the sound of the crack. It's how the person's positioning their foot. It's how their hips are positioned. If you get, and it's the same with exercise, right? If you position yourself, and PNF, it's the same with mobilization.
Everything.
It's the same with all of it. The idea of the body is to try and be as biomechanically as efficient as possible. That's ultimately what we try and do. We try and move weight. We try and lift in a biomechanically effective way. If you do it badly, it will come and bite you in the arse.
Yeah. I think that is the reason when you teach, every time you ask the therapist to look at your butts.
Look at my arse. look at the booty. Look, right. And this is true though, right? With manual therapy, forget the arms. Forget the arms. Hands, biceps, it's irrelevant. That's why small practitioners, little female practitioners can just can be just as effective as big burly guys. The power of the technique is hips, back, glutes, legs, body position. Look at martial arts, okay? You look at someone standing there trying to punch someone like this, and they'll last 20 seconds. But you see someone who's using their body to actually do all this sort of movement effectively. Man, it's beautiful to see. It's effective. It's really, really graceful. And, you know, the key emphasis is it's safe for you. You look after these, yeah, and that will have a big impact on your, because look, longevity. You haven't spent, how long was your degree, Rohit? How long was your degree?
So, I believe, I believe it, totally like glutes, legs, everything matters, the body position. Like when I do the PNF with my patients and like I'm treating like 7 to 8 patients every day right now as well. 6, 7 patients together, like with my therapist. So if I'm treating 5 patients and I'm doing the PNF on their shoulder, I'm doing PNF on the spine, lower left. If I do not maintain my positions, I'm going to hurt my back probably. The first thing I'm going to hurt is my shoulder and my back. So what I do sometimes that when I'm walking closely on their spine or the couch height is low, especially, I just get my stance into the wide, I just put my wide stance so that I can stabilize my hip and then I can work on very well. So that sometimes we have to change our position according to the height of the couch, the area which we are going to treat. So we have to adjust accordingly.
Listen, you know, you're young, you're strong, you can get away with it. But if you get good practice now, you get good principles now, they will set you up for the future. The key is to make sure that's the key. I saw, we had a student once who was massaging a patient, massaging them, and she slipped and she fractured her thumb like that. That was from massage, okay? And she ended up coming on a course in a hand cast. That's an extreme example. But I've injured myself doing treatment. I've seen therapists injuring themselves doing treatment. You shouldn't be at the end of your clinical day going, oh my God, I'm exhausted. You should be going, oh, I feel fine. I was biomechanically effective. I was, you should still have the energy to go to the gym if you wanted to after clinic. It's really important you get that. And not many people teach it, unfortunately.
Yeah. 2 of the very important tools which I use in my treatment is resistance and approximations. And not only I use my hands to give them, sometimes I use my different body parts like my hip, my back sometime, my thigh sometime to give for the approximation or for the distance. So that it's not, we need to know as our body how we have to adapt to the environment, how we should keep safe ourselves. So that's very, very important, I believe.
Yeah, and do you know what? Not only that, it's the equipment you're using. I've seen some people using cheap couches that are too low, that are too high, or the therapist has just been too lazy to change the height of the table. Something as simple as bringing it up, bringing it down takes you 2 seconds, and you're like that. Changing the height of the table could actually make a huge difference to the actual treatment process and the effectiveness of the effectiveness, the ease at which you can do something. I think it's really, really important, guys. Also, if you've got any questions, chuck them out there. Jimmy's sort of manning the OMT official page. Make sure you follow us. So if you've got any questions, please also chuck it out there whilst we're talking through. But yeah, I mean, changing something as simple as how you're positioned around the table, the height of the table, will make massive issues. In short, explain cervical artery
Mukul is there. Mukul.
Well, what are you talking about? Are you talking about the vertebral artery or the carotid artery? Come on, sunshine. The 2 are different. There's one at the front, one at the back. Each has different aspects. You've got to factor that in. You've got to be a bit more specific, sunshine. But actually, Jimmy's made point. We talked a lot about arterial compromisation in the recent book we published, because with neck manipulation especially, although statistically, depends on the research, but 1 in 5 million is the statistical risk for a vascular compromise in the cervical spine due to manipulation. you still want to make sure you're safe. And ultimately, neck manipulation is a much safer modality than taking some sort of over-the-counter pain medications or anti-inflammatory medications. But as we always say, safety and technique should only be applied once you've gone through the full safety processes. With neck manipulation especially, it has to be appropriate. Yeah, that's my key thing, right? I can crack a neck very well, but I don't crack everyone's neck. And this is actually, do you know what? I think, again, this comes into safety. I'm sure you've seen it, Rohit, on on social media, the videos of people just cracking the necks of their patients. I've got a knee problem. I've got a knee problem. Crack the neck. Sorry, carry on. What were you saying?
Exactly. But like if we are talking about the cervical manipulations, I see lots of videos of the therapists all across, like they go severely in extension and rotation, and then they give the crack. And like some of our patients are connected with us today. So like how safe it is. I mean, being a therapist, like how should we make it safe for our patients when we're about to do these manipulations?
Well, look, I'll say it now. Ultimately, every technique you do has an element of risk. Okay, PNF has an element of risk. Massage, dry needling, iastin, exercise, crossing the road, eating a sandwich. Everything you do has an element of risk. Okay.
Exactly, yeah.
All right. So we get that. Risk is managed through our clinical screening processes, our case history, patient selection, and not using the technique on everybody just because it sounds good. For me, a neck manipulation should only be used if it is clinically appropriate. Okay. Now, when we talk about actual, you said extension there. From my perspective and OMT training, my colleague Jimmy, we don't use extension, which is where the chin sort of comes up.
Yeah.
In any form of neck manipulation. It may be taught by some other professionals. It may be taught because it was used a long time ago. But ultimately, as we've progressed through the last 15, 20 years, technique is getting safer, and the techniques that are potentially very risky are now not being taught. Okay. We don't use extension as a primary vector in neck manipulation because there is a theoretical risk that we can compromise the vascular structures in the cervical spine. If there is a theoretical risk, I'm not a fan of even going down that route. Okay, we avoid it. We tend to utilize things like flexion, side bending, and rotation. The emphasis with neck manipulation is the technique is small. If you're turning your patient into an owl, bang, to try and crack a neck, you can't do it well. It's brute force. It's finesse over force. That's why we teach how we teach in such specific ways. There are screening tests that you can do to make sure the patient is not adverse to vascular compromise. We can look at vertebral artery testing, although specificity is very poor. We can look at the carotid artery. We can do vascular screening processes. We can look at if there's any form of muscle weakness around the eyes, anything that could indicate compression of the internal carotid arteries. Again, presentation, things that may be indicative of vascular compromise would be part of our screening processes. But what I don't like, and I would always say Jimmy and I and yourself are probably some of the safest practitioners in the world, although I'm very well known, as my colleague is as well, for being able to manipulate. And you see stuff and you'll see me do stuff. Ultimately, when I have a patient, the key with those techniques is knowing when not to do it. The key is also, if you are going to do it, to make it as finesse and as gentle and effective as possible. That's the focus. We do that, again, like I said, through clinical case history. My argument is that if you crack the neck of every single patient that comes in, regardless, then at some point, you're going to come unstuck. At some point, if you're cavalier in your attitude and you just crack people for the fun of it, you're going to have a problem. If you are using techniques and modalities after clinical rationale and because of your clinical judgment, then you are ultimately going to be a safe practitioner. Safety is key, ultimately.
Right. I think I love this comment of Jimmy. Like he's saying, the actual movement is not the meter. So like for the therapist, like who just move the neck or the back, whatever, so much before manipulation. It's not that movement. Actually, you need to get that.
Yeah, do you know what? We test it, we treat it, we retest it. Do you know what annoys me? Maybe I'm a perfectionist, but what really bugs me is bad technique. It's bad technique. And I see a lot of people being dentists.
Yeah.
Yeah. And then I see a lot of therapists videoing themselves and they basically are going on, bang. And they put so much power into it. If I'm having to use that much power to get a little click, then do you know what? I think I've missed the point. You know, there's easier and safer and more gentle ways to do something. And Jimmy's right there. Don't make up a diagnosis just to justify what you're doing. That's also a lot of the time. Some people will do that. They will just justify to themselves that they actually, oh, you know, it's definitely this, bugger it, I'll just crack it anyway. That making stuff up. If you're not sure what's going on, that's fine. We all make mistakes. We don't know everything. Have the confidence to go, I don't know. It's not a problem. You know, that's confidence. I think that's key.
I think ego is one of the concern here with some of the therapists, you know, I believe so. So
you guys, what is it with India? You guys, man. It's not just India. It's all over the world. Ego is a problem.
Yeah. Ego is the problem.
Yeah.
So one of my major concern right now, which I can see just all around, like everybody has come in the teaching right now. So I'm not talking about the manipulation only. Like if I talk about different techniques, without being expertise, I think that everybody has right to teach sometime in their life. You know, like suppose you are learning today, you are having a good clinical practice for 4, 5 years, 6 years. You do some own research work and all, and then you get into teaching. If you have those skills only, but what is happening right now that somebody is doing a course and just getting started teaching after a week or after a month or after 2 months, and you know they are taking big subjects. Now what is happening that the other therapists who are learning from them, they might hurt their patients based on the knowledge they are taking from them. So this is a big concern right now. The people need to understand from whom they should learn, and they should bring it into the practice.
Look, I have no problems in people teaching. Okay, I don't have a problem with people teaching, and I think competition is ultimately a good thing because it makes us all work harder. I'm not the only person that teaches manipulation across the world, but getting published and start teaching, yeah, I'm not the only person that teaches manipulation as well. I think what annoys me though. What I think is dangerous is people saying that they're qualified to teach certain techniques when they aren't. That's dangerous, in my opinion. For me, I spent 5 years doing a master's program, 5 years doing a degree program in osteopathy. I did 5 years, okay. That allows me to call myself an osteopath. I don't like it when someone does a 2-day course, a 2-week course, and then finishes that and then says that they're an osteopath and then starts to try and teach that, because I think it's a bit disrespectful to the profession overall. If you want to be an osteopath, a chiropractor, or a physiotherapist, I think it's fair that you should do the full educational process. Okay, get the full qualification. If you want to teach Pilates, for example, my friend Alison teaches Pilates. She's spent the last 20 years going through the UK and the US accreditation programs. Okay, in the UK, it's about a 12 to 18 month program. That's what creates good, safe technique, good, safe teachers. I don't think after a 2-day or a 4-day course, you have the knowledge, the experience, or the skill to teach that clinical technique. You need experience. We didn't start teaching until we'd done our degree program, we'd done research, we'd been published. We actually, you know, because I believe that as a teacher, I need my students to be able to leave my class safe. They need to be effective. They need to be able to understand clinical implications. They need to understand when not to do something. And I think it's important that, and I say that because I come from a regulated country. In England, an osteopathy degree is regulated by law. You cannot call yourself an osteopath, a chiropractor, or a physiotherapist unless you have done that process. It's also a concern for patients, because my argument is, if a patient is attending a therapy session with someone who says that they are a chiropractor or an osteopath, yet they don't have the fundamental understanding or the knowledge, there's a safety element there. It's a concern. It is a concern. As a student, if I was going to attend a training course by someone, I want to know who they are. I want to know what qualifications they have and where they studied. And if they say they're a chiropractor or an osteopath or a physiotherapist, I want to make sure that they actually are, or they're not pretending to be, or they're not trying to sell me something just to make money. We love what we do because we see the benefit to the patients. This, for us, actually, it's almost like a lifestyle. And Jimmy's right. No country is immune to this. In every country, this is a problem. But I think in order for us to move forward, you have to have the confidence to say, look, I'm a physiotherapist, but I've done training in osteopathy and chiropractic technique. I use that as part of my treatment process. Be comfortable with who you are. If you're a chiropractor, that's fine. I've worked with physiotherapists. I've done physiotherapy training, but I'm not a physiotherapist. It's an in-depth, it's an issue. And again, I think a lot of it's ego. People love titles, people love certificates, people love certificates on walls. They like to sound cleverer than they actually are. And I think people need to be realistic. If you're teaching chiropractic technique and you haven't actually done a chiropractic degree, a proper regulated degree, then I think you're lying. If you are teaching osteopathy or osteopathic technique and you haven't done an official 5-year master's program or an accredited university program, and you're saying that you're teaching that stuff, again, I think you're lying to yourself and you're lying to the students. It's the same as if someone is pretending to be a physiotherapist. Unless you've done the educational program, I think it's a very difficult process. Students need to be aware.
This is such a big concern. Yeah, this is such a big concern. The new students, the final year students, the third year physiotherapy students, the interns, actually. So most of them, they're not able to check the credibility of the instructors. And nowadays, anybody is coming into teaching the Pilates, the chiropractic, the osteopathy, and this thing and that thing. And, they are being learning not the right things, actually. And then they are being practicing on their patients. So this is really, really sad part. Somehow they need to understand this.
And you know what? Like I said, it's a concern, because I see rival training providers, and do you know what? Look, Jimmy and I have written 1, 2, 3, 4. We've written 4 books. We've published 5 or 6 scientific research journals. We're finishing off another one. We teach all over the world. We teach evidence-based manual therapy. We teach it from an osteopathic perspective. We teach what we believe is current best clinical practice, safe technique, safe guidelines. Okay. What concerns me is I see people out there offering training courses and promoting things in their advertising, which is absolutely fundamentally wrong. It is. They are there. One guy was actually, I won't mention names. It's in a public forum at the moment, but he was advertising, I can treat posture with 1 appointment. I can treat fertility. I can treat infertility with manipulation. I can treat autism with manipulation. I can boost your immunity with this. I can do that. I can do this. He was purporting to be using manipulation to treat a variety of systemic issues and neurological issues, which scientifically and evidence-based you cannot justify. Now, as a student or a new graduate student going on that form of training, you are going to be learning things that are fundamentally wrong. Not only that, but you're going to leave that course believing that, And yeah, quackery, absolutely. You're going to believe quackery, nonsense, rubbish, and you're going to start telling this to patients, and you're going to start utilizing these modalities for something that shouldn't be used for. I believe as an educator, if I'm going to be teaching students, it's my duty to have the qualifications, to understand the modality inside out, that I can adapt it. It's also my duty to give you current evidence, current research, and to tell you that this part of the therapy is good and this part is bad. Osteopathy is great, but it has many, many flaws. Osteopathy has many, many flaws. Chiropractic has many, many flaws. It's my duty to put them all out there. Don't go on a course just because it's cheap. Don't go on a course because the guy is purporting to be able to tell you that they can treat everything with one technique. Don't go on a course because you think someone is a guru therapist. You have to do due diligence. You wouldn't buy a house without doing full due diligence. You wouldn't go and do a degree program without doing full due diligence. You have to do this with your training, because it will set you up. And for us, we are very open about what we do. You can see what we do online. You can access our research. You can access our books. You can see what we do. And I think it's very important that you make sure that when you are learning from people, that you're not being ultimately taught rubbish, taught bad technique, and being lied to. You just and question. I'm a big believer in being questioned, and I'm very much open to say, look, I'm wrong, or I don't know, or I'll find out. My way is not the only way. There's a million ways to do it. There's a million things that can be done. I don't believe I am the best in the world. I'm good at what I do, but there's millions of people out there. You've got to do due diligence. Safety is really, really important, because you go into clinical practice and people are going to be relying on you. You're their primary healthcare provider. It's so important.